Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sapp. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and to review core topics. Today's edition of Conversations from the World of Allergy will focus on the topic of Aspirin Exacerbated Respiratory Disease, or AERD. It is also known as Samter's Triad, or NSAID Exacerbated Respiratory Disease. We'll learn more about the pathophysiology of AERD and how to manage these patients. We are pleased to welcome Dr. Tanya Laidlaw. Dr. Laidlaw is an associate professor at Harvard Medical School and the director of translational research in allergy and the director of the AERD Center at Brigham and Women's Hospital in Boston. Her research is focused on understanding AERD, nasal polyps, and aspirin and NSAID allergies. She follows a large cohort of AERD patients and has a research lab looking into the mechanisms underlying this disease. Dr. Laidlaw, thank you so much for taking the time to join us today. Is it okay if I call you Tanya?
Please do, yes.
So I'd like to start just by getting to know you a little better. Can you tell us a little bit about yourself and include something you like to do outside of medicine?
Sure. So, I'm an allergist and immunologist at the Brigham Women's Hospital, and I think largely what we're going to talk about today is sort of my role as the director, of the Aspirin Exacerbated Respiratory Disease Center. But, I was born and raised in Massachusetts, and both of my parents were scientists and teachers here. And, my work with AERD is incredibly fulfilling. But outside of medicine, I'm also a proud mom of two amazing teenagers. And together with my awesome husband, Nick, we keep life as fun and adventurous as we can. So as a family, we're really active. We love traveling and outdoor adventures. So just in the last 12 months or so, we've been snowboarding down Whistler Mountain, snorkeling in Puerto Rico, surfing in Hawaii, and cliff jumping off the islands of Greece, where my family is from. So when I'm not adventure traveling, you can usually find me in the kitchen. So I grow vegetables and herbs in our backyard kitchen, in our backyard garden. Much of my cooking is influenced by my Greek heritage, and there's sort of generations of women surrounding me all the time, sort of guiding me as I cook. So food is my love language. And so whether it's hosting a gathering or just sitting down to enjoy a meal with my family, I love to eat as much as I love to cook. So that's a good thing. I like all the adventure activity as well.
That's a lot of travel. That's wonderful.
Love it.
And what made you choose allergy immunology as a specialty?
It's hard to pinpoint the initial sort of trigger. Was it a patient in residency that I found fascinating? Was it, reading new research? So I don't know that I can pinpoint the exact moment, but I think overall it was a feeling that I was drawn to allergy and immunology because the immune system is the world's most intricate puzzle. So it's complex, it's mysterious, it's sometimes unpredictable, not always in good ways. And so I think I was drawn to trying to understand more about how little tiny shifts in immune function can then lead to either protection from disease or disease itself. And I kind of wanted to be part of the effort to understand that puzzle and understand those mechanisms. So I think, I was drawn to allergy immunology also because it sits so clearly at the intersection between science, research, and real world patient impact as well.
And AERD, which we're going to discuss, is one of those really interesting immunologic phenomenons that we don't totally understand, but are learning more about over time. Tell us, what is AERD?
So AERD is best defined as sort of a clinical syndrome or clinical triad, and most patients have the following three symptoms. One is asthma. Two is nasal polyps, so chronic rhinosinusitis with nasal polyps. And third are these pathognomonic respiratory reactions to aspirin or NSAIDs or any medication that inhibits the COX-1 enzyme.
And aspirin is not, of course, the only NSAID. It's all NSAIDs, better known as NERD or NERD in Europe. Why don't we call it NSAID Exacerbated Respiratory Disease or NERD here?
So the original name given to it was Aspirin Exacerbated Respiratory Disease, or AERD, about 30 or 40 years ago, maybe in the 80s. And at the time, aspirin was really the only medication that was widely available that inhibited COX-1, so it made sense. Since then, we now have a whole class of medications we call NSAIDs. And so NSAID ERD is probably a technically better name for it. And I'm more than willing to use NSAID ERD as the name for it. When we shorten it further to just NERD or NERD as an acronym, it just doesn't work in the United States. And so my patients end up giggling if I tell them that they've been diagnosed with NERD and I can't run the NERD center. It just wouldn't make any sense at the hospital. And also for patients to be able to use a search engine to find their own symptoms and diagnose themselves. You can't look up the word nerd and come up with anything that's helpful in terms of respiratory disease. So I tend to stick with AERD because it makes more sense in the US.
That makes sense. And AERD is actually an adult disease primarily, but you trained as a pediatrician. So what made you excited about AERD?
So the fact that I'm a pediatrician is largely because I just like kids better than adults. So I'd rather hang out with kids of any age than adults in general. That being said, I landed with AERD, quite frankly, because when I started fellowship here at the Brigham Women's Hospital, I joined the lab of Dr. Joshua Boyce. And he had a few projects kind of going on in the lab, and I was pretty open-minded and agnostic about what disease to work on. And he started describing this disease, aspirin exacerbated respiratory disease. And in fact, because I was a pediatrician, I had never seen a patient with a disease. I hadn't even heard of the disease. And so I didn't have any of that concern, I don't want to ask the dumb question about it, because I knew it was going to be understood that it was okay that I didn't know anything about this disease. As a pediatrician, I wasn't expected to. So as they were describing, and in my mind, I had this vision in the lab with Dr. Joshua Boyce, Dr. Al Sheffer, and Dr. K. Frank Austin, who were all there in the lab talking about projects ongoing and the confusion in the disease, sort of real huge giants in the field. And I started kind of asking some general questions. Why is it more common in women than men? Well, why does it mostly just develop in young adulthood and not in children? Why does it only cause nasal polyps, but not polyps elsewhere, like colon polyps? Why does aspirin cause respiratory reactions? And why is it that you can desensitize patients? And why is it that high doses of aspirin make them better? And the answer to every single one of my questions was, we don't know. And so in the end, I think Dr. Boyce got a little annoyed at me and he said, well, why don't you go find out? So I think I've always been fascinated by fields when there are more questions than answers, and AERD is exactly that. So I set about studying the disease from kind of a laboratory perspective and basic science perspective. But at the time, we still knew so little about the disease 20 years ago that there was no way to have either an in vitro model of it or even a mouse model of it, because we didn't know what to do to the mouse to make it develop AERD. And so I had to study patients. And so I ended up meeting every faculty member in the Boston area, and everyone remembered their few AERD patients that they followed because they're so complex and they're so hard to treat and so confusing in many ways. That I'd get the list of 3 or 4 patients, and each time a patient was going to be seen, I would call them and ask if they were willing to participate in a clinical study. I was going to draw some blood, maybe collect some urine, and every single time these patients were so incredibly appreciative that anyone was kind of looking into the complexities of their disease. More than one patient would say, do you want me to come to your house and give you a urine sample? Like, where have you been for the last 10 years? Yes, please study me. And the doctor in me really started to feel fulfilled that I had found a group of patients that really wanted to be studied and to be understood, and they really needed help with evaluation and treatment and getting their lives to a healthier place. And so I saw a place that I could kind of move into, both with the nerdy lab science, but also with the doctoring skills that I really enjoy.
I mean, these patients were also asking those same questions, and their doctors were largely, I don't know why you have nasal polyps and why when you were taking ibuprofen just fine a year ago and now you have these terrible reactions. So I can definitely understand their appreciation for someone wanting to ask the hard questions.
Yeah. And I am always honest with my patients that I still don't know the answer to many of those questions that I had asked right back in fellowship, but that I'm never going to stop working to find out.
Well, tell us what we do know about the pathophysiology of AERD.
Yeah, it depends on how kind of nitty-gritty we want to get into it, but I think we can sort of start with general broad kind of sweeps. AERD is probably like the prototypical what we call type 2 inflammatory disease. So any possible sort of cell or mediator that is described to be involved in type 2 inflammation is totally involved in AERD. So there are really high numbers of mast cells in the nasal polyps and in the lungs of patients with AERD, lots of mast cell activation, lots of release of things like leukotrienes and prostaglandins that cause inflammation, tons of eosinophils. These patients have eosinophilia in their blood, their nasal polyps are full of eosinophils, their lungs are eosinophilic, lots of basophils, lots of epithelial dysregulation, all the classic type 2 cytokines, IL-4, IL-5, IL-13, all very high in patients with AERD. The innate cytokines sort of in that pathway as well, TSLP, IL-33, also very high in AERD. Pretty much everything that we can check off that would count as kind of type 2 inflammation, including high levels of IgE, even though it's not really an allergic disorder, are super high in AERD. So we know for sure that type 2 inflammation is there and is involved and is extraordinarily severe in these patients, especially in the respiratory tract. But we also know that it doesn't all make sense. So even though they have this very classic type 2 inflammation, they're often not classically atopic. So they're not allergic necessarily. So these aren't necessarily patients who have food allergies and eczema and even a lot of environmental allergies. Many of my patients do have environmental allergies, but not really at a higher rate than we see in the general population. So we're not really sure what's driving all of this extraordinarily severe inflammation.
Do we know anything about what kicks off the process? Because this is, classically patients don't have a history of asthma in childhood. They're not atopic, going back to, oh, I had so much trouble with, pollen when I was a kid. So what kicks it off?
That is the very short answer is I still don't know. So how you describe the patient is really what we see, right? Patients will come very confused, right, in their 20s or 30s and say, but I was such a healthy kid. I was not the kid wheezing and sneezing with, my classmates. I was fine. And only in my 20s or 30s did I often quite suddenly develop severe nasal congestion, lost my sense of smell, and developed asthma kind of all at once out of nowhere. Many of us who see a lot of these patients will tell you that we've heard over and over from patients that they often feel as though they got a really bad cold and that kind of just never went away. And they feel like they wake up every morning still with a really bad cold. A long time ago, we had looked to see if there really were actually any respiratory viruses sort of left in the nose of these chronically inflamed patients, and we couldn't find anything that supported that at all. But I believe my patients. I think it does sound like what their symptoms are. Is it possible that actually they're entirely right, that there was some really bad viral upper respiratory infection that caused a cold? And that even though the virus itself, the infection has been cleared now months, years later, somehow the body's immune response to it hasn't shut off. And really, your body does wake up every morning somehow confused and thinking that there's still a virus there to fight. That's a theory. We don't have a ton of evidence to support it, but I think it makes some sense. We've also talked a little bit about the sort of gestalt, if you will, that it kind of feels a little bit like an autoimmune disease. Again, it's a little more common in women than men, tends to happen in adulthood, not childhood. Once you have it, it's not transient. Um, and there are high levels of antibodies, especially in the nasal polyps of these patients. Again, we don't really have proof of that, but it's something that we're working on now to see if we can understand more about those.
I know these patients have a dysregulation of kind of their leukotrienes and prostaglandins. Um, how does that play into the pathophysiology of the disease?
Yeah. So those dysregulations and those what we call eicosanoids, lipids, are something that's actually been known in the fields of AERD for decades and really well studied by others as well. So the one that's talked about probably the most is LTE4 or leukotriene E4. So that's the end product of cystinoleukotrienes. And patients with AERD tend to have really high levels of leukotrienes in their respiratory tract, both in their lungs and in their nose. And it can even be detected in the urine because it's a stable M metabolite and in the plasma. So even at baseline, just on a random day when they're feeling well, our AERD patients walk around with much higher leukotriene levels. And then interestingly, during the aspirin-induced or the NSAID-induced reactions, like while the reaction is happening, those already high baseline levels go up much higher, sometimes twofold, sometimes more than tenfold higher, both in the respiratory tract and in the urine. And we're pretty sure that that extreme rise in leukotrienes that happens during the reactions to aspirin is one of the main driving mediators that causes the reaction. Because when we use medications that specifically just block leukotrienes, those reactions are much, much, much less severe and blocked. So we know they play a role. What we don't understand is why is it that taking aspirin, ibuprofen, causes a rise in leukotrienes? We do not understand that. We have some theories, but none of them really explain the entire thing. Perhaps even more confusingly than that is sort of the other side of the pathway is a production of prostaglandin. So prostaglandin D2, PGD2, has gotten a lot of attention in the last few years, both from our group and from others. So really, it should be that things like aspirin and ibuprofen that inhibit cyclooxygenase enzymes should inhibit the production of PGD2 because it's a COX product. And in the long run, they do. So patients who are on daily aspirin therapy, their PGD levels do go down. But acutely, during the aspirin-induced reaction, an hour or two after taking aspirin, along with the super high rise in leukotrienes, you see this parallel rise in PGD2 acutely during the reactions, both in the respiratory tract and in the urine. You can detect the metabolites. And that's really confusing because I just gave my patient a drug that should block the enzyme that you need to make PGD2, and yet they're making way more of it. So we're still definitely behind, in the field of figuring out why that is happening during those reactions.
And it's such an acute bronchoconstrictor. And so
Yes.
really contributing to these respiratory reactions that patients are having.
We definitely think it plays a role for sure.
And these polyps are chock full of eosinophils, and they're clearly involved, but there seems to be kind of other cells they're involved. And if you block eosinophils, it's helpful, but not necessarily completely. Is that right?
Yeah. So this is one of the, well, we hadn't thought it was a mystery, but then we discovered that it actually might be a mystery. So known for decades is that the nasal polyps, as you said, are completely full of eosinophils. Sometimes if you look at them, if they're surgically excised, and you look under the microscope, nearly half of every single immune cell in that nasal polyp from an AERD patient is an eosinophil. They really shouldn't be there. So something's wrong. And if you had told me a decade ago that you were going to have a medication that reduced all the eosinophils in the tissues, I would have said this is phenomenal. This will cure all of my patients and I will happily retire early. Great. So then a couple of things happened. And this is when really paying attention to clinical trial results can be important because negative trials can be as informative as positive trials, although usually more disappointing. There is a medication called dexpramipexole that is not currently FDA approved for anything at all, still in trials. And it was noted in earlier trials for other diseases that it depleted eosinophils from the peripheral blood. So the company chose to look into whether or not it could treat patients with eosinophilic nasal polyps and AERD. And so we participated in a study, a couple dozen patients with eosinophilic nasal polyps who went onto this medication, dexpramipexole, for 6 months. Almost instantaneously, their blood eosinophil counts went to close to zero. And we did nasal polyp biopsies really carefully at baseline and then again 6 months after being on the medication. And just really striking decrease in eosinophils in the tissues. Was crazy to look under the microscope and see how incredibly removed these eosinophils were from the tissues. Essentially eosinophil free. So the drug worked beautifully. The problem was that the patients didn't actually get any better. Their polyps didn't get smaller. They didn't feel better. They weren't less congested. Their smell didn't come back. So we somehow managed to prove that you can get rid of all of the eosinophils in an AERD patient's nasal polyp and they don't get better, which is just odd. Fast forward to now, we have a couple of different IL-5 or IL-5 receptor inhibiting biologics that are FDA approved, some of them for both asthma and nasal polyps, others just for asthma or other hypereosinophilic syndromes. And they are certainly anti-eosinophil for sure. And They do have a pretty good set of efficacy, I would say, for the asthma symptoms in patients with AERD. We really get some pretty striking benefit in our patient reports of asthma control and improvement in lung function as well. But even in the AERD patients who have very clear comorbid nasal polyps and eosinophilic asthma, who go on to an anti-IL-5 biologic, we often find patients will come back and say, thank you, my asthma is so much better, but my nasal polyps aren't. So now I'm further confused, right? So is it that there's some IL-5 responsive cell in the lungs that isn't there in the nose, or is it that there's just additional kind of like backup inflammation pathways in the nasal polyps that we haven't gotten rid of yet? We're not sure, but it certainly needs some more investigation.
Absolutely. And the only way to diagnose AERD patients is really looking at their clinical history and then doing an aspirin challenge in the clinic. There's not really any other diagnostic test. If you were to design a diagnostic test down the road, what do you think we would look for to diagnose them without having to go through this aspirin challenge?
Yeah, that's a great question because I would love to not ever have to do diagnostic aspirin challenges again. Many of our patients come with such classic symptoms that we don't ask them to do a formal aspirin challenge, right? If you're a 27-year-old who has adult onset eosinophilic asthma, nasal polyps that have recurred after surgery, and you remember two different instances when you took both naproxen and ibuprofen and developed a respiratory reaction, I'm going to believe you. I'm not going to require you to do an aspirin challenge just to prove it to me. But we have lots of patients who just don't take NSAIDs. So they're not sure if they had a reaction. They don't really remember. They aren't super sensitive to their own symptoms. So they honestly just shrug and can't tell you if it made them any worse, who really do warrant some kind of diagnostic evaluation. And you're right, we're left with aspirin challenge to do it. So I don't think there are any baseline mediator values in AERD patients that are going to be distinctly different enough and consistently different enough from non-AERD patients, right? Because we're not comparing them to healthy controls. We're comparing them to patients who otherwise have asthma and nasal polyps, but not the aspirin or NSAID sensitivity, where there's going to be a simple blood, serum level or urine level or even nasal fluid level that I'm going to say, oh, because your PGD2 or leukotriene or whatever is so much higher, you definitely have AERD. There's just too much diurnal variability to those, day-to-day variability to those, that I don't think we're ever going to get a really good sensitivity and specificity from something like that. So I suspect that we would need some kind of in vitro aspirin challenge, where we figure out what it is that aspirin actually does to you systemically to cause the reactions, and somehow can then model that in a test tube instead, so that I do the aspirin challenge, but I just do it to your cells and not to your whole body.
Yeah, that would be great to be able to measure those, leukotrienes and prostaglandins in a test tube by some sort of method. But we're not quite there yet. We'll get
No,
there.
I wish. Yeah.
So, in addition to their respiratory symptoms, some patients have these really significant GI symptoms. Why do some patients get GI symptoms, and what's causing those?
So the why or the what, what causes those patients to do it, we're not entirely sure. We do know that from some recent studies we've done that the patients who tend to get the GI symptoms, and I want to make sure people sort of respect these GI symptoms because they can be really, really severe. So, incredibly severe abdominal pain. We've had patients sort of on the floor in the fetal position in pain. I've had patients vomit. It's about 10% of our patients during aspirin challenge will develop a GI reaction, but when it happens, it really can be very miserable. So one thing that we've noticed in those patients is that they tend to be the ones who produce and release the most prostaglandin D2, the most PGD2 during those reactions. Is it that it's the PGD2 itself that is somehow causing vasodilation and actual sort of reaction in the gut? Maybe. Or is it just that PGD2 is paralleling some other mediator that's really causing those reactions? We're not sure. And we're not sure why those patients are the ones who produce more PGD2, right? Are there mast cells in the gut specifically reacting to the aspirin? We're not sure about that. The other thing about those patients, just for clinical sort of correlates, is that unfortunately for the patients who do develop those severe GI symptoms, they tend to be the patients who are the hardest to then desensitize to aspirin. It's not dangerous, right? It's not a super severe fall in FEV1 or lung function, but it just kind of suggests that the immunologic process that they have to go through to develop desensitization and achieve desensitization to aspirin is often not going to work as well in them. Or when it does, it requires us to be extraordinarily patient, and often we'll end up having patients slowly increase their aspirin dose at home to see if we can get underneath those GI reactions and still get them to the best dose.
Do they respond equally to the biologics we're now using in AERD?
Great approach. So yes, they do. I have not noticed anecdotally any difference between the patients I remember having had horrible GI reactions and how well they respond to biologics. I will tell you that these days we have so many biologics available that when new patients come to me, and if they tell me a story of, here are my symptoms, here are my reactions to aspirin or ibuprofen, and oh, by the way, also during my respiratory reactions, I had really horrible, gut pain, abdominal pain, vomiting. Those are patients that I might sort of steer away from suggesting an aspirin desensitization as their first approach to therapy. And I might suggest that we would start with a biologic for them and skip over aspirin desensitization, unless there's other reasons that aspirin would be very important for them.
Now, you work really closely with ENT, looking at post surgery, the nasal polyps. How do you are there ways that we manage our patients in allergy differently than the ENT patients? Is it best to co-manage them? And what do you find is really helpful in creating a good relationship and communication pathway with ENT so you can co-manage?
Yeah, this is incredibly important for these AERD patients who have comorbid polyps. So, in terms of differences in management approaches, I mean, ENT physicians often focus on the surgical, right, on the mechanical aspects of managing AERD with, addressing the nasal polyps with sinus surgery, as that's a cornerstone of their care. It can significantly improve sinus drainage, reduces inflammation, enhances the efficacy of intranasal medications like steroids, whereas allergists don't do surgery. And so that's an area where there's a complete dichotomy, right? If a patient really needs surgery, I am not going to be managing that. My ENT colleagues are. Allergists are also trained in immunology in our fellowship in this country. And so we tend to focus on things like systemic inflammation and immunomodulation through therapies like leukotriene modifiers and biologics and aspirin desens. And so those approaches are different. They're also complementary. And for most AERD patients, successful management of their disease requires a combination of both. So I think having a team to work with in terms of ENT colleagues is incredibly important, and approaching each patient, care as a team effort is incredibly important. So I find it helpful to discuss cases collaboratively, right? Especially when we're making decisions about the timing of surgery versus the timing of things like a biologic. So, for example, surgery might not eliminate the need for medical therapies like biologics or aspirin desensitization. So, kind of aligning the patient goals is crucial, and making sure that my ENT colleagues share with me sort of their understanding of this patient's anatomy and whether or not they think for this particular patient, surgery or repeat surgery is likely to be the best approach. And making sure that we avoid giving our patients conflicting advice, that we're kind of all on the same page. So, in terms of how to make that work, frequent communication, I think, is an obvious answer, but that can be just one-on-one discussion of patients that you share, but it can also be more formal, right? Like sort of regular case discussions, like joint patient consultations, educational opportunities. So I'm honored to be invited to provide kind of allergy-focused education to ENT colleagues at ENT conferences. And I also find that actually doing collaborative research with our ENT colleagues and including them and them including us in those approaches really ends up kind of strengthening the professional bonds between you, but also then improving patient care because you know how each other work well.
Yeah, that collaboration in terms of some patients, you start them on a biologic, but they could still really benefit from some surgery. Working with the ENTs for timing is so important to really get the best outcome for the patients.
Exactly.
So one thing I have definitely heard from my patients with AERD is this phenomenon of when they drink alcohol, their symptoms get so much worse. Sometimes it stops patients from drinking alcohol and sometimes it doesn't. It kind of depends on the patient. But certainly I think we've all heard that. What's causing that? And what do you advise patients?
Yeah. So this is a phenomenon that we first published on a little over 10 years ago with a sort of cross-country survey. So we had as many patients as we could collect here, and we worked with a Scripps Clinic team in Southern California for as many patients as they could collect there, and found that somewhere around 80% of patients with AERD do report exactly what you just described, that drinking alcohol worsens their respiratory symptoms. And listeners need to know that this is not a case of getting intoxicated. The patients will tell you that it happens within drinking less than one glass of alcohol. Usually starts within 15 to 30 minutes of drinking the alcohol, with nasal congestion and runny nose being the most common symptoms, and about half those patients also developing some lower respiratory symptoms like wheezing or shortness of breath. So yes, it happens. It can actually also be an additional diagnostic clue for patients who come to you where you don't know if they have AERD or not. Maybe they've never taken an NSAID before, but if they hint that they also get these alcohol reactions, it's just one more hint that maybe this is the right place to be looking for a diagnosis. Your question about why it happens, again, the short answer would be we don't know. Several of us in the world of AERD have tried to investigate this a bit further. And the Scripps Clinic team actually did a study that they had nicknamed the Happy Hour study for a little while, where they did formal alcohol challenges in patients with AERD. And they noticed and published that for patients that were pre-treated with a combination of both montelukast and antihistamine, the reactions seem to be at least somewhat abrogated, although not necessarily completely gone. So it seems to provide a little bit of improvement. We have noted and have some new survey data that will be coming out later this year in publication, that patients with AERD who are treated with dupilumab for at least 3 months, the vast majority of those patients who then try alcohol again will tell you that the alcohol-induced reactions are improved while they're on the dupilumab. The same is true for many patients who are on high-dose aspirin after desensitization. We aren't sure if that's because the aspirin itself somehow is affecting the reactions to alcohol, or that the high-dose aspirin is working to keep their nasal polyps at bay, and so they're just in general have less inflamed tissue to be involved in the reaction. My suspicion is that mast cells are involved in those reactions, and that somehow alcohol or an alcohol metabolite directly induces mast cell activation, but we're still working out the dynamics of what exactly is going on there.
I mean, that would make sense because we see that with some of our hive patients as well. When they drink alcohol, that seems to increase the release of their mediators. They get itchy, their hives flare. So we see that phenomena in other diseases as well.
Agreed. And I suspect there the mast cells are also maybe the culprit.
Yes. And then are there any other foods or exposures that seem to cause symptoms in these patients with AERD?
So yes, although it's going to sound funny for anyone who hasn't had their patients talk to them about it. So it's actually been found that a number of patients with AERD, a decent portion will tell you that certain kinds of mint flavorings, toothpaste or menthol, will cause mild asthma reactions. It's real, it's replicable. I totally believe them. I honestly can't tell you why. I more just validate that the thing that they've been thinking that they were crazy, that their toothpaste made them wheezy and congested. No, it's really happening, but I honestly don't know why.
Fair enough. And you also had looked at diets with omega-3 fatty acids and seen a difference in patients' response to that.
So this comes down to a little bit of the nerdy knowledge about those eicosanoids we talked about earlier. So it turns out that we know that we think glucotrienes and probably prostaglandin D2 contribute to the disease, and our patients just have way too much of them, both at baseline and after aspirin reactions. We also know that both of those mediators are derived from something called arachidonic acid as their precursor. So if you don't have arachidonic acid in your body, you can't then make glucotrienes and prostaglandins. So arachidonic acid is like the building blocks for it. But you can't make arachidonic acid if you don't eat the building blocks. And those building blocks come from omega-6 fatty acids. So theoretically, if you completely fasted totally for an entire month, which I don't think is a good treatment suggestion for AERD, you would lose all of your body's stores of PGD2 and LTE4 and theoretically could get better. So in fact, the dietary trial that you mentioned was inspired by a gentleman who told me that he did just that. He had said, doc, in the 1970s, when it was trendy to fast, I took a whole month off from eating. I just drank tea and juices the whole time. And I have to tell you, I felt like I was on prednisone. It was like before I even had the disease. I was so much better. And I kind of giggled and didn't believe him at first, but I actually had a few other patients tell me something similar. And so we looked into it. And I don't know whether or not actual omega-3 supplementation, which is what a lot of patients prefer, it's a little bit easier to just take a fish oil capsule than it is to make dietary changes, would make any difference. My suspicion is that the dietary modification that makes the most difference is actually reducing your consumption of things that have omega-6 fatty acids in them. And for some patients, that's not a whole lot of change to their diet. For some patients, it's a huge dietary shift depending on what their basic diet is on a usual week. So we counsel patients who are interested in trying that in how to avoid as many vegetable oils and seed-based oils as they can, because that's really the largest sort of culprit for where we get high doses of omega-6 fatty acids in our systems. And for many patients who are able to stick to that diet for even just a few weeks in a row, they really do note like a rather sudden and dramatic improvement. And so for some patients, it's something that they will use intermittently when they're sort of not feeling well. If they're just trying to avoid going on prednisone, sometimes they can do a really strict omega-6 fatty acid diet cutout and will feel better for a couple of weeks.
It's nice to have something to try. Oftentimes, patients do want something that they can do to kind of own the disease and feel better. So that's one option. Probably the best treatment we've had up until recently, which we'll talk about in a second, is aspirin. How well does aspirin work in patients that are desensitized?
So the studies are actually reasonably hard to do and to do well. So there haven't been very many prospective, double-blind, placebo-controlled trials of high-dose aspirin therapy after desensitization. There's some ethical implications to doing them, and frankly, placebo-controlling aspirin is really hard because aspirin itself has a fair amount of effect, and so patients know if they're on placebo. So taking all of the data we have together and all of the anecdotes from those of us who have done this a few hundred times, um, high dose daily aspirin, so either sort of 650 milligrams up to 1200, 1300 milligrams a day, when given to patients uh, at a time when they do not have nasal polyps, right? So usually right after surgery, when their polyps have been taken out, we try to do the desensitization and give the high dose aspirin. Will prevent or significantly delay their polyps from growing back in about around 60 or 70% of patients. And in the patients for whom it works, it really can be pretty magical. And they're really just on aspirin for years. And they see me every 2 years because they don't even need me to prescribe everything. And then in the patients for whom it doesn't work, we also find out pretty quickly because 3 or 6 months later, their polyps are already growing back, and we can agree that that just didn't work and we need to shift into something else.
And it's been so surprising to me how well patients do tolerate 650 or 1300 milligrams of aspirin a day. Actually, they have some bruising, maybe a little bit of GI upset, but just shockingly well that they can tolerate this.
I agree. And often their primary care doctors will call me and think I'm crazy that I've put their patients on such high doses. And I have to reassure and say, no, like it's really surprisingly well tolerated. Yes.
You've made a mistake. That's too much aspirin. Like, no,
Right.
no, that's what we want them to do.
Exactly.
So now we have biologics that are so effective in AERD. What biologics are really the most effective in studies, and what do you find yourself reaching for now?
Sure. So in terms of what we have available to prescribe, we really have a couple of classes. One is omalizumab, anti-IgE. We have the anti-IL-5, IL-5 receptors. I'm going to lump those together. We more recently have anti-TSLP and tezepelumab that at the moment is only approved for asthma in trials for nasal polyps. And then we have dupilumab, the anti-IL-4 receptor. Um, Although this isn't in the chronological order in which they were trialed, it's pretty clear that especially for patients with AERD, dupilumab is the most efficacious, both for their asthma and for their nasal polyps. I would sort of estimate that upwards of 90% of our patients with AERD will have a really impressive therapeutic benefit from dupilumab, and usually within the first month of starting it. It's fast, it's efficacious, and for the patients who really need it, it can be absolutely life-altering. Other trials have shown there's some efficacy to the anti-IL-5s. Again, with our discussion earlier about eosinophils, I think actually we've all been a little bit disappointed. We thought they would have worked better for our ARD patients than they do. So not efficacious, but I think not quite as efficacious as dupilumab. Omalizumab does have some role and does provide some benefit. It also seems to reduce the severity of aspirin-induced reactions, which can be helpful for patients. As a side note, dupilumab often will also reduce the severity of aspirin-induced reactions. Not so reliably that I tell patients it's now safe for them just to take NSAIDs if they want to, but it's something that we can approach doing a challenge in the office on dupilumab to see if it's safe for you now to take NSAIDs while you're on it.
And then tezepelumab is still being studied, but I imagine it may have a similar role. I think we'll see in the future.
I agree. And so those data are actually coming out really soon. And in terms of what we've seen anecdotally from prescribing it to our AERD patients for their asthma, it does seem to be pretty efficacious for those patients and maybe for their sinuses as well.
So if a patient is on a biologic doing well and they need to take aspirin, would you recommend they come into the clinic?
I do. So we haven't had any real evidence to suggest that being on one of the anti-IL-5 pathway drugs is helpful at all for the aspirin reactions. Those seem not to have any effect at all. I don't really have any data about whether or not tezepelumab is efficacious in that way. And omalizumab and dupilumab can be really helpful, but not enough that it's a clean slate to just take the NSAIDs when you want them. So those patients, I would still have them come in and do a challenge in the office.
Do you still do aspirin desensitization on the biologics sometimes?
So rarely, but yes. So there's a couple of cases when we would. The number one case is going to be someone who actually just needs to be on an NSAID for some other reason, right? Is this cardio protection? Is it because you have chronic pain for other reasons, arthritics, et cetera, and we want to be able to give you something for pain control? We'll do a desensitization for that reason. And we do have patients where really it appears as though being on their daily aspirin and a biologic like dupilumab is the magic bullet for them. And we need to have the patients on both things for them to get the full benefit that they deserve.
What do you think are the most important questions that we still need to ask in AERD? We've come up with a lot of them, but what's the next steps we need to look at?
I'm going to hesitate to say this because I think it's such a sort of far-reaching pie in the sky dream that I don't know that I'll see it in my lifetime. I would really like to know what causes this darn disease, and so that we have a ability to detect it early and prevent it from progressing. So we are so stuck with dealing with chronic inflammation that by the time the patients come to us, it's been at least months, usually years, that they've had the disease. And it seems much too late at this point to be able to go back and turn the sort of inflammatory immunologic clock backwards. So I want to be able to figure out what is the inciting immunologic trigger for the disease so that when it happens, we can stop it from progressing.
And what advice would you give to young researchers coming into the field of allergy who are trying to figure out what to study
In general,
in general?
ooh, that's a great question. I would say some of it is emotional and some of it is practical. So the practical side is, you probably need to be somewhere where your mentor or your team or your research colleagues have some expertise in the area that you're going to study so that you can learn from them. It's really hard to go in cold and try to learn it all on your own. From a practical standpoint, I would also say that there are some fields that are really super saturated with lots of research already going into that area. That might be harder to then come in 20 years behind everyone else and try to build your own cohort where it's already happening at major centers elsewhere. So maybe look for something that's a little bit less saturated. And then from the emotional side, I would say, if you're going to do research, you have to really care about the questions and the answers. It has to be that when you're here early mornings and late nights, you're excited. You're like eurekaing about the cool new thing that you just discovered and that you can't wait to tell, your colleagues, your patients, the public about it because you think it's important. And so I think being driven by just like the joy of really understanding human disease and making human health better, you have to pick something that you care about.
I love your story how when you came in, there were all these questions that you kept asking because it was such a fascinating field for you. And the answer was, I don't know. And you just had to go out and figure it out. And I love that.
I'm still trying to figure it out.
That's right. Well, thank you so much for being a guest. And we loved hearing about AERD.
This was so fun. Thank you so much.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at quadai.org. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast so you can receive new episodes in the future. Thank you again for listening.